Okay, here we are for video number 2 of the central nervous system. In this video, I would like to discuss the outline of medications that we are going to be going over throughout this particular unit. And I want to introduce signs of central nervous system stimulation and depression. And I'd like to also talk a little bit about drug abuse, tolerance, physical and psychological dependence, and addiction, because that is a very important discussion that needs to be had around the utilization of a lot of these CNS drugs. Okay, so posted on the website, you have an outline. And if you have not yet printed that outline, now would be a good time to do that, because it's going to give you kind of an overview of what we're going to be talking about in terms of drugs. And you want to be super familiar with that thing before your next exam, ideally. And ideally what you would be doing is you would be reviewing that outline daily, in a perfect world, multiple times a day, and continue reviewing it until the organization and the drugs and the uses for those drugs and the classes, and etc., become super familiar to you. That will make this particular unit go a lot more smoothly. This is a big topic, central nervous system drugs, as I'm sure you can imagine, and we obviously are not doing a very deep dive into the subject matter here because we just don't have enough time. So instead, what I've kind of tried to do is pick the major classes and how to hit the highlights of the major classes, and why you would use these things therapeutically, along with contraindications and cautions for use. But it's going to be pretty surface. You know, if you want to get a better understanding of these agents, which will be probably necessary at some point in your education, you're going to have to get into it a little bit more deeply. But this is not the time to do that. Okay, so that being said, we are going to start off in the next 2 videos are going to be on central nervous system stimulants and depressants. And those are kind of specialized sorts of drugs because they have a overarching kind of an effect on the central nervous system. One of which is stimulation and the other of which is depression. So I'd like to, in this video, just kind of run you through some signs of some stimulation and depression so that you can recognize that when you either are analyzing a patient or when you're learning about the drugs. You'll have sort of an idea of what to expect with these things. So in your book, you have something called a continuum chart, which looks like this. And this chart is just a general way to kind of get familiar with signs of central nervous system stimulation and depression. So in this chart, in the middle, we're starting with the normal or neutral state. And anything above that normal or neutral line would be a sign of stimulation. Anything below that normal or neutral line will be a sign of depression. And we're going to sort of look at trends here. So starting off with central nervous system stimulation. So provided that somebody is starting at the normal or neutral state, when we're using a central nervous system stimulant as a medication, they're most likely not starting at a normal or neutral state. We're trying to get them ideally to that normal or neutral state. However, if they are starting at a normal or neutral state and they are administered a central nervous system stimulant, not a very potent one, but this first sign of central nervous system stimulation is known as euphoria, which is sort of this feeling of elevated mood. A little bit stronger stimulation or a stimulant at a higher dose, we might precipitate feelings of anxiety. More stimulation yet, or a stronger stimulant. We may see signs of tremors and or hallucinations, followed by convulsions and or seizures, and at the top of that would be death. Most likely as a result of the convulsion and potentially acidosis or something along those lines. Flipping this the other way, looking at signs of depression, one step below the normal or neutral line would be sedation, which is a state of drowsiness. A larger dose would be hypnosis, which is a state of arousable sleep. So they go to sleep, but they can be aroused or woken without too much difficulty. And then we have general anesthesia, which is including a loss of consciousness, or encompassing, I guess would be a better way to say that. So when we say general anesthesia, we are going to synonymously think of a loss of consciousness or unarousable sleep, followed by a coma, and then death, usually by respiratory depression, which we'll talk more about in a little bit. So in a general sense, signs of stimulation generally shows increases in both sensory acuity and motor activity. Signs of depression are going to include a decrease in both sensory acuity and motor activity. So those are just sort of a kind of a snapshot of stimulation versus depression. And when we talk about the drugs individually and potential therapeutic uses, we'll kind of come back to this conversation. This continuum chart is something that you want to be familiar with. Definitely be able to pick out signs of stimulation and depression, what happens when you increase the potency of your stimulants or increase the dose of your depressants. All right. So let's just think here about the central nervous system drugs for a minute. So if you go back historically, which we don't have to go back very far because drugs haven't been around all that long, but historically the CNS drugs were either stimulants or depressants, or classified, I should say, as stimulants or depressants. But that classification was a little bit misleading, because as we dive into these drugs, sometimes we'll have a situation where a drug can be used and it might stimulate one area of the brain and potentially inhibit another or depress another area of the brain. So a lot of the drugs that we'll talk about have sort of a dual effect. But the classic central nervous system stimulants and the central nervous system depressants, if they are a true stimulant or a true depressant, they are going to either increase the activity entirely of the central nervous system, that would be a stimulant, or decrease entirely the activity of the central nervous system, and that would be a depressant. So we're going to kind of start with those, and then we'll talk about the agents we refer to them as selective modifiers of the central nervous system, meaning they may stimulate only one area of the brain, or in some cases they may stimulate one area and inhibit the other. So we'll get into that as we get into some more specialized uses for these medications. Before I get into the central nervous system stimulants in the next video, I do want to have a conversation around a couple very important concepts, and that is drug abuse, dependence, and tolerance. So these drugs, the central nervous system drugs, are mostly controlled drugs. And I'm not sure if you remember about controlled drugs, but controlled drugs are scheduled drugs. And the schedule of drugs ranges from Schedule 1, which is going to be used only in research facilities. Never, ever, at least not anytime soon, will you see a prescription written for a Schedule 1 drug. But any drug that's placed on the schedule, so either Schedule 1 through 5, they're placed there because they have a potential for abuse and or dependence. So that's a really important thing we have to consider when we think about central nervous system drugs. This issue of drug abuse and dependence on these agents is reaching epidemic proportions. There is definitely a crisis in this country, specifically around painkillers, most oftentimes opioids, but there are a lot of people in really serious trouble with our central nervous system stimulants and depressants for various reasons. So I feel like it would be remiss to not have a conversation about this prior to really diving in and learning about the drugs. So most of our central nervous system drugs, the stimulants like methamphetamine, the depressants like the barbiturates and the benzodiazepines and alcohol, and the opioids, which are used, they have a depressant activity as well, but they're used generally in the management of pain. These drugs are all scheduled drugs, and they all exhibit dependence causing propensity or characteristics. So we really have to kind of think about that. So I'll start with something that's a little easier, I think, which is, well, sort of easier, which is this concept of drug abuse. So it kind of depends. Yes, we kind of have to, there's different ways to sort of approach this conversation. And one way is to think solely about pharmaceuticals and clinical use. Another is to expand it to both recreational and pharmaceutical use. And I think the expansion of the concept is important because there's a lot of overlay when we look at abuse and abusive behavior between street drugs and prescription drugs, and oftentimes the use of one will lead to the use of the other. And so I think that kind of historically we think of drug abuse and we think of just recreational use of medications and or street drugs, illicit substances. And that's kind of where we sort of draw the line with abuse, is if somebody is using something recreationally and or they're using an illicit drug, then that would be classified potentially as abuse, versus if somebody's using a prescription medication, then that is not oftentimes referred to as abuse, or we're not thinking about it maybe quite as readily. So drug abuse is pretty difficult to define in some instances, specifically within the context of prescription medications, I think, at least. This is open to, discussion, debate, and other people are going to have we're going to all have differences of opinion potentially around this. Some behaviors, are easily to recognize as abusive, and oftentimes we think of that more again around the recreational or use of illicit substances. Traditionally, when we think of drug abuse and we sort of label something as abusive behavior, that labeling conveys the notion of chronic use and or social disapproval. What it does not oftentimes deal with is kind of forward thinking and looking at the potential for abuse when we are really more specifically dealing or thinking about prescription medications. So anyway, this topic kind of has to get, it's huge. It's a huge topic. So, we can think of it from different ways. The two most commonly abused substances are nicotine and alcohol, right? Both of which are perfectly legal, but still chronic use could and is by some people considered abusive. By other people, it's not abusive at all, so there's quite a lot of gray area here. When we think about maybe using the term drug abuse in the context of behaviors that potentially have adverse effects, then both drinking alcohol and or smoking cigarettes would be considered abusive, right? So we have to, again, sort of place things in context. When we apply this to prescription medication use, it gets even more muddy, because in many cases, the medication is prescribed in all cases of controlled substances, the medication is prescribed by a physician for some sort of therapeutic use. A good example on the slide here is drugs used for insomnia, which is very common, and these drugs are prescribed in huge numbers. And if you dive into the research around drugs for insomnia, and the class of drugs that are used most oftentimes for insomnia are central nervous system depressants known as benzodiazepines. The benzos are used for sleep disorders, specifically insomnia, or people who have a hard time going to sleep or falling asleep or staying asleep. But if you dive into the literature, how these drugs were researched and approved were for short-term use. In most cases, no more than 14 days. And what the literature shows is that after about that 14 days of use, the drug actually starts to become less effective. But many people, for whatever reason, and it can be complicated, are on these drugs for, months and years. And one thing we know about those drugs is the longer you are on them, the harder they are to come off of them. And the withdrawal symptoms coming off of these drugs are horrendous in some cases, and they can be quite prolonged, which we'll discuss. But just taking all that away, if somebody's taking a drug for years, let's say to sleep, and it's probably not effective anymore, that could potentially be considered abusive. So it's an interesting and complicated topic to engage in. Kind of along this same context, I'm moving towards dependence. I want to introduce a term called tolerance. Tolerance is essentially a physiologic state characterized by a reduced drug effect with repeated use of the drug. So essentially what that means is that in order for the drug to be effective, the dose has to continually be increased to achieve that desired clinical effect. Whether it be in a reduction in anxiety, a decrease in the perception of pain, an mood elevation. There's many drugs that exhibit tolerance, and that's generally something that is given to you if you go to the extent of reading a drug manual. So in this state of reduced effectiveness, the issue with them, the thing that makes this kind of complicated is because of the fact that these are scheduled drugs, and because of the fact that if they exhibit tolerance, and you can see on the bottom of the slide there what drugs absolutely exhibit tolerance, and those are all the narcotics, of which opioids are an example, barbiturates, alcohol, benzodiazepines, and tobacco, nicotine, right, all exhibit tolerance. So that means in order to continue to get the benefit or achieve that desired clinical effect, you have to continually increase the dose of the drug. And what we know about all of those drugs, also, they're all scheduled drugs. They all have a potential for abuse and or dependence. And the longer you stay on them, the more likely somebody will become dependent on them, and more likely that they may engage in abusive behavior. So that's complicated. Why this happens, this tolerance, we're not really sure exactly, but it most likely has to do with either as the body gets more accustomed to having that drug and or those neurotransmitter levels elevated and or depressed, depending on the medication, we probably are seeing an increased elimination of the drug. So the body kind of wises up to it and tries to get rid of it faster. Or probably more likely is there's a drug receptor interaction. And what seems to be make the most sense is that we see an increase or decrease depending on the scenario with the amount of receptors, the number of receptors, or the receptor density for that particular compound at the synapse. And so if we change the receptor density, we're going to change the way that drug acts in the body. And that probably has something to do with tolerance as well. So for example, if over time, fewer and fewer receptors are inserted for that particular drug, then in order to maintain an effect, you have to continue to take more and more and more of the drug. So there's more drug available to hit the receptor when the original drug is released, or when the original compound is released. So that is referred to as down-regulation of receptors. We also, in some cases, see up-regulation of receptors. So that's probably a very important part of this tolerance discussion and this concept of what's really going on and why is it? That's the real question. Why is it that we have to increase the dose of the drug in order to maintain the effect? And it is in the increasing of the dose of the drug that we potentially are getting people into trouble. Tolerance is always part of the deal when someone is becoming physically addicted to a drug. So there's, or physically dependent, I could say, even that it sounds less judgmental, physically dependent on a drug. So this concept of dependence, there's kind of two ways to look at dependence. Remember, when a drug is scheduled, it's put on the schedule based on its potential for abuse and or dependence. So the higher it is up on the schedule, meaning like a schedule 2 and 3, the drugs are going to have both a high degree of potential for causing physical as well as psychological dependence. So physical dependence is an adaptive physiologic state that occurs after you administer a drug that by itself manifests physical disturbances when you take it away. So basically, this is an adaptive state that occurs when you take the drug away. They develop physical symptoms, and those physical symptoms oftentimes are referred to as withdrawal syndromes. Psychological dependence is a little bit more complicated. It's a state of emotional reliance upon a drug, which means that in order to maintain a state of well-being, they have to feel, they feel like they must have the drug, right? So this is more of a central nervous system, kind of a psychological dependence on a drug as opposed to a physical dependence on a drug. When we talk about withdrawal symptoms, we in relationship to psychological dependence, they refer to there not being withdrawal symptoms, but I think really what lacks is physical symptoms, like potentially seizures or things along those lines. It's not that they don't have a sensation of needing the drug. If anything, with the psychological dependence, they seem to be more compulsive about obtaining the drug, right? Because they feel like their emotional state is reliant on the drug being present. So probably in most cases with most drugs, especially drugs on the schedule like 2, 3, and maybe even 4, they're most likely causing both types of dependence at the same time, right? So there's really a continuum of dependence, and a lot of drugs, especially those that are high up on the schedule, have features of both physical and psychological dependence. So that's something to kind of look into when you're thinking about drug therapy, or talking to patients about how they're dealing with their drugs, is to kind of, have a working knowledge of if they're on one of these medications, what sorts of things you're going to be on the lookout for. Taking this to the extreme, we have addiction, and addiction always implies a compulsion, especially involving the central nervous system drugs or the endogenous central nervous system compounds, right? There's a lot of people that become addicted to behaviors, perhaps, that cause a change in the neurochemistry, release endorphins or dopamine, etc., like gambling is what I'm kind of thinking of here, or excessive shopping, or sex addiction, or something along those lines, where it's not a drug necessarily, but it's an endogenous compound that's still releasing chemicals in the brain, right? And altering neurochemistry. So anytime there's addiction, there's always this sort of compulsion aspect to the picture. I think I said this earlier, but the 2 most commonly abused substances are both perfectly legal for adults and readily available, and those are nicotine and alcohol. Right? And again, that's where that gray area of abuse, where do you draw the line? What do you consider abusive? And I think all of us would answer that question, or most of us would answer that question very differently. In terms of prescription drugs, the biggest players currently are for addiction and dependence. Well, no, actually, I'm going to take dependence off, because there's a lot of problems. There's a lot of drugs that are going to be equally efficacious in terms of dependence. But most commonly abused prescription medications are oxycodone or Oxycontin, which is the brand name or the trade name of that, methylphenidate, which is amphetamine, a stimulant. Adderall is an example. Ritalin is another. And then alprazolam, which is a benzodiazepine commonly referred to as Xanax. These are probably the 3 most frequent drugs of abuse. With the opioid epidemic happening, the Oxycontin is a big time player there, and there's a whole bunch of other opioids as well, which we'll kind of get into. You're not responsible for knowing those names, but I did want to introduce them because of their importance in this context. All right. So just in terms of things to look out for, I have, I think a lot about this, and I try to feel like what's the appropriate level of information to sort of disseminate at this level with this particular kind of survey course. But most people taking this class are headed towards some degree in some career in the health professions. And so we are all going to be having to recognize this problem more and more frequently every day until we get a handle on this. So there's a couple characteristics I think that are important for whoever is the person that's interfacing with the patients. The more time that somebody is spending with them and talking, the more likely you are going to be able to elicit some of this information. So one characteristic of abuse is craving. Craving is a big deal. So when someone's craving a substance that they know that is definitely lowering their quality of life, that is generally a sign of physical dependence, and that is also a characteristic of abuse. If they're not able to maintain their normal work-home relationships because of the substance, right? If they're using this substance repetitively and it's getting in the way of their life, that is a characteristic of abuse. If there's recognition that they have to keep increasing the dose in order to achieve that same level of clinical effect or therapeutic effect, that's another characteristic of abuse. If they've made repeated and unsuccessful attempts at discontinuing the substance, that's another red flag. Any kind of recognition that there are behavioral changes occurring with the use of the substance when it's discontinued. So when they take away the substance and they recognize that they feel, agitated or anxious or, in some cases they're going to have other physical pains or headaches or, it goes on and on. Those physical symptoms are a sign of withdrawal syndrome. There's going to be psychological symptoms as well when somebody discontinues a drug, and a lot of that's going to be around the compulsion and kind of what we've mentioned before. And then when it gets a little bit more advanced, maybe there's a kind of an increased amount of time or even an obsession around obtaining the substance, which takes away from other things they should be doing, working, spending time at home, relaxing, etc. So those are things to think about in terms of abusive behaviors. So when you have a patient that is on a medication like a benzodiazepine or an opioid or a stimulant, it's kind of good to have these kinds of things in your mind and work it into the conversation to sort of try to elicit some information to see if this is what you've got going on. Okay, here are some common withdrawal symptoms and treatments for some of the drugs of abuse. And I'm not going to spend a lot of time. You can look at some of these things on your own. What we're going to talk about in our class mostly, and not the next video, but the one after, the fourth video, will be on the depressants, the barbiturates, and the benzos. So both of these are known to produce some of the most crazy withdrawal symptoms around. And you can kind of see how they look. They tend to hang around for a long time, in some cases months. So and alcohol, they're going to have the same. Really, benzodiazepines, alcohol, and barbiturates are all central nervous system depressants. So they're going to kind of look the same in terms of withdrawal. Amphetamines, we'll talk about central nervous system stimulants, mostly around the treatment of ADD and insomnia. But you can see these guys are also going to cause some withdrawal symptoms. That would be physical dependence, and psychological in many cases as well. And then the opioids will be later on, but you can see they have quite excessive withdrawal symptoms also. And then if you're interested in treatment, you can kind of check it out over here in terms of how you have to go about treating these withdrawal symptoms. In many cases, it requires inpatient treatment centers to do this effectively. Slowly, especially in the case of the benzodiazepines, really tapering off the medication slowly. And there's strategies around how to taper, and it has to be adjusted for a patient. Some people can taper pretty easily. Some people can go cold turkey. Some people can't get off of them for love or money. So it sort of depends. And for that reason, it has to be kind of approached, in my opinion, from a patient by patient basis. Okay, so that is that video on abuse, tolerance, dependence, the concepts around that, and addiction, and just some general information on CNS stimulants and depressants. In the next video, we're going to talk specifically about central nervous system stimulants, I don't know if you could hear my dog making that crazy noise. So I will be back later with more.